students, welcome to Dr. Ram's Medical Coding Academy. Today we are going to see a short video about this E&M service in medical coding. Now what's an E&M service? Some say it as an EM service or an E&M service. Here you'll be surprised to know that we have a separate specialty in medical coding as an evaluation and management service coding. This is a different specialty of medical coding, and not all coders know how to report an E&M code. I'm going to call it as an EM code. E&M coding is an interesting coding specialty, and today we'll talk some specifics about it. Now, how will you arrive at an EM code, or how do you report an EM code? The EM code selection is based on several factors. We have codes based on the patient type, whether the patient is a new patient or a follow patient. We also call it as an established patient. If you are a new patient to a doctor, then you will be having a separate set of codes. And if you are already a follow patient to the doctor, the EM coder will assign a separate series of codes. Next, the codes differ based on the place of service. Where exactly is a healthcare service being rendered? Accordingly, the code differs. And then we have the most confusing and the confounding levels of service. We'll talk about the levels of service in the separate videos because it is not easy for you to understand at a fresher level. But I'll tell you how we can select an EM code. An EM code can be reported based on three key components. We call them as the HEM. H-E-M, the HEM. So H for history and E refers to the physical examination and M is for the medical decision making. We'll talk about each of these components separately and more elaborately in the subsequent videos. These three key components are needed in arriving at the appropriate level of service with certain exceptions. Apart from the key components, now we also can select the codes based on the contributory factors. You can very well see in this slide. So what are all these contributory factors? Nature of presenting problem. The patient is presenting with a problem. Is it a minor problem? Is it an acute problem? Or is it a chronic problem? Or an acute condition with an exacerbation? Or a worsened severe condition, which is a chronic condition? So all these we need to analyze. And based on the time that the doctor spends with the patient, we can report a code based on time that is being spent with the patient. If the doctor is going to render counseling, then we can report based on counseling. But we have a well-defined route as to when we can select a code based on counseling. The same is true for care coordination or coordination of care. Now, your healthcare provider can contact several other healthcare providers. So the time the doctor is spending in coordinating the care is also counted towards the selection of this EM code. Let's see some of the EM services. So what possible services can amount to a reporting from the EM section of the CPT manual? We have the consultation service. The patient is having a consultation with a specialist, maybe a cardiologist or a neurologist. So he wants to have an opinion about the surgery. He wants a specialist's expertise and advice. We have the observation service, where a patient is being seen in an emergency department. The patient is kept under observation. Not all times you make a personal visit to the doctor, isn't it? Now, during these COVID times, now there was so much of internet services or non face to face services. Patients were not present physically at the doctor's office or in the hospital. So we have like internet services or telemedicine services, telehealth services. Like that, we also have a telephonic service. And imagine you are being admitted in a hospital, then that becomes an inpatient service. If you remember, I was telling you that the code selection depends on where the service has been rendered. We call it as POS. POS is a place of service. If it is going to be a doctor's office, it is 11. Now the patient is being seen as an inpatient, so we have the POS code as a 21. If the patient is being seen as an outpatient in a hospital, then we can report that as a 22. So these are all non-medical code sets. So according to the place where the patient is receiving the treatment, now we can set the EM codes as office visit codes. An office is nothing but a doctor's office. We say it as a clinic in the Indian parlance. Next, there is a hospital visit. So the codes differ. A home visit, where the doctor visits a patient's home, and a hospice care, where the patient is suffering from a life threatening condition. The patient is in his final stages, say like a stage 4 of a cancer, where the patient's days are counted and he is receiving care in a hospice. The codes will be different. Same way, a patient visiting an emergency department will also have a different set of codes. Let's see a small example with which you will understand how to report the EM codes. Rani is a follow-up patient who presents to Dr. Rajan's clinic for her sugar levels as she is a type 2 diabetic. Doctor takes her vitals and examines respiratory and cardiac systems and advises to continue the old prescription metformin and spends 22 minutes. Here, if you see the codes, we have used 99213. Now, if we go and see the description under code 99213, where the doctor typically spends around like 20 to 29 minutes. Here, the physician has spent 22 minutes. The EM code can be selected based on the time that the doctor spends face to face with the patient. With the new guideline, we can report the office visit services based on time or MDM, the medical decision making. Since Rani is seeing the doctor in his clinic, now we can report it as 99213 considering the time and she is a follow-up patient. The diagnosis code is representing the patient's type 2 diabetes mellitus condition. I hope you understood and I will see you in the next video. Thank you very much for watching.